Oh, that's fine.
Great. Thank you very much. I think it's for the first time also that TAVI is a major part of the new guidelines. MitraClip also just made it, but of course so far there was not a lot of evidence to prove that TAVI might be indicated in some patients. Therefore, before these guidelines appeared, there was a statement paper that was produced by the ESC and the ESC-EACTS on which patients and under which conditions TAVI could be an alternative. So, but now they're also part of the guidelines. So first, I think what we have to know before we read these guidelines, we have to put this into perspective of life expectancy of patients. And that's one of the issues that actually we don't always realize that well. This is the projected life expectancy of people who are 80 years of age, so the Dutch population. And of course, you see that in 1921, it was still quite dismal, 5 years, but up until 2012, and it's now about 8 years, 9 years for men and women, that they still have to live when you're the age of 80 years. And you'll see there will be an increase of life expectancy over the years up until 2015, but you see there the increase is rather small. The big jump that you see there around 1945, 1950 was due to the beat of the infectious diseases by the introduction of antibiotics. That was a major step forward in healthcare in general. And then, of course, you see the curve slowly progressing. Now, what we also have to realize is that there are several ways how you can die. You can die suddenly, a sudden death. Myocardial infarction is, of course, an example that we all know of. Then there's a terminal illness. So you're very sick, malignancies, and at a certain moment, you know, the patient then dies. And there's this function, type of function that you can, trajectory that you can die is due to organ failure. There are some ups and downs here. Renal dysfunction is a good example of that. Patients may function a little bit better than worse, etc., but finally they will die. And then there's this one that you can die due to frailty. And I think that's a lot of the patients that we see nowadays that are possibly candidates for a TAVI implantation. You may solve the TAVI problem, the aortic stenosis problem, but of course there might be other diseases that will come in the years after. And a British Medical Journal article last year had the title, "Where do you want to die from?" Because you may solve one thing, but then another disease may appear. So, and that's, of course, the physiological reserve is on the y-axis, and the age is on the x-axis. And you see that a lot of patients, it started with, for example, hip fracture, then they get a pneumonia, congestive heart failure, functional limitations, and then finally disability. And so also the quality of life diminishes over time with increasing age. So we think that we all get older and older, and that's true. The whole population gets older. The average age that somebody dies is, you know, increased very much in the last couple of 30 years by about 10 years. So that's a huge increase of life expectancy. So it goes from 74, 76, 78, and now it's in the Netherlands it's almost 80 years for women and 78 years for men. And actually it's also interesting that the gap between men and women becomes smaller. And you see that from 1900 until 1999, the proportion of people that survived up to 90 years increased very much. You see that it was both true for men and women. But now if you look at the proportion of people that live up to the age of 100, you see that there the increase is not as much as in the other decade of from 80 to 90 years. And so you see that we increase with age, we get a better life expectancy, the average age of the population increases, but there's a kind of a cap there, so that we don't get 130 or 140 years old, most probably. So what are now the unknowns that we have to deal with here? Unresolved issues are this with TAVI implantation. So once we consider all these new therapies in this elderly patient population, we have to also realize that there are still a lot of issues that we need to solve. Pacemaker issues, stroke, anticoagulation, we don't know yet. Paravalvular leakage that may also have an impact on life expectancy. Vascular complications that also are predicted for mortality after the procedure. Responders versus non-responders. There's a kind of cohort C that are so sick and so old and so frail that even if you give them a TAVI, they don't respond very well. Then there's bicuspid pathology that still is relative contraindication for TAVI. The durability is something we don't know yet. We implant these valves in elderly patients. They don't have a long life expectancy, so we don't actually know the long-term durability of these valves. Up until so far, it's quite good. I mean, there are not a lot of dramatic reports that valves start failing after 5, 6, 7 years, but it's only a small patient population that survived up until that age. Then there's TAVI and TAVI, and we don't know how that will evolve and what the durability of those valves will be. Then the important question, how to risk stratify patients, which patients benefit from surgery and which ones from TAVI, and which ones don't benefit at all. And how to evaluate new systems. Do we always have to start a new randomized study to prove when an iteration comes out? So then the guidelines, what do the guidelines then tell us? With all these unknowns, I hope that the guidelines now will give the answer. Let's see. Well, this is written, first there's another guideline, let's say in between, because we want to do studies to learn more and to produce guidelines. There are people who write guidelines and people who want to make guidelines, and this is actually how to make guidelines. It's the VARC paper which produced guidelines on how to report on trials and how to report on studies in TAVI and in aortic valve surgery. But this is the guidelines from the ESC and ESC-EACTS. What are absolute contraindications to TAVI implantation? Well, first, the absence of a heart team. There has to be a surgeon and cardiologist who decide how the patient should be treated. Appropriateness of TAVI as an alternative to AVR is not confirmed by a heart team. So really the heart team is crucial here. Both have to be convinced that TAVI is the right approach for this patient. When the patient has a life expectancy less than 1 year, there's also a contraindication for TAVI. Of course, also, you know, the outcome of the procedure might be quite dismal because it means that the patient is in bad condition, but also there's a societal aspect because TAVI is quite costly. And if the life expectancy is less than 1 year, perhaps you should not do that. Improvement of quality of life by TAVI is unlikely because patients have other diseases as well. Associated disease of other valves and mitral valve disease, tricuspid valve disease that necessitate also other operations on the patient may also be a contraindication to TAVI. And then there are some anatomical contraindications. Inadequate annulus size, less than 18 millimeters, although now there is a valve size that is used only in Japan, because they're much smaller than we are, that we currently can use as a 17 millimeter valve. Maybe we'll see that in the future as well. Thrombus in the left ventricle, active endocarditis, and the risk of coronary obstruction. Not always easy to predict, but when you have a chance, when the coronary ostium is just a little bit above the annulus, you have to be very careful there. And of course, when there are plaques with mobile thrombi in the ascending aorta. And we as surgeons know that very well. Sometimes when we open the aorta, we can remove the stenosed aortic valve, but there might be sometimes calcium in the ascending aorta, and when you touch it with your forceps, it falls apart. And then we always think, well, how can you play with your wires in the ascending aorta and not induce thromboemboli? Then there are relative contraindications. For example, bicuspid valve, which I just mentioned. Especially the coronary ostia are very important in this regard, and also how the calcium is distributed, whether it's symmetrical or asymmetrical. Untreated coronary artery disease requiring revascularization, and we now know that a lot of these patients can either, stenosis does not need to be treated, or we can treat it with PCI and then can do also a TAVI implantation. Hemodynamic instability, those patients do very bad. I think the first patient that Alain Cribier also treated were those ones that came in a hospital who were really hemodynamically unstable. But some you may save, but a lot of these have a very high risk. Left ventricular ejection fraction less than 20%, very unlikely that they will benefit from TAVI. And for the transapical approach, it's of course severe pulmonary disease. You do a small thoracotomy, you open the left pleura, there might be some pleural effusion there, which may impair the pulmonary function after the procedure. So what are recommendations then, the more positive side? Again, here you see a lot of level C, 2 level Cs and 2 level Bs. And of course, thanks to the partner trial, we can now say, well, at least there was one randomized study that showed the role of TAVI. So TAVI should only be undertaken with a multidisciplinary heart team, including cardiologists, a cardiac surgeon, and other specialists if necessary. Very high level recommendation, but of course there's not much evidence for that. TAVI should only be performed in hospitals with cardiac surgery on site. Again, highly recommended, level C, expert opinion. TAVI is indicated in patients with severe symptomatic AS who are not suitable for AVR as assessed by the heart team. And of course, that refers to the partner 1B trial, where there's a 20% difference in mortality at 1 year in favor of TAVI versus medical therapy. So 1B. And TAVI should be considered a high-risk patient with severe symptomatic AS who will still be suitable for surgery. And that, of course, refers to the partner 1A trial, and that's a 2A recommendation with a level of evidence B, of course, also only one trial. There's still some doubt because we only had, at that time, there was only the 1 year follow-up of the partner 1A, and now there's much longer follow-up. So these guidelines, of course, can already next year, the year after, can be updated again with all the new results from the studies that are undertaken. Then, of course, this is the most important. We have heard about this already. So there's a rationale for the heart team. There's only, you could say, a level of evidence C. But what we did try to do here is try to come up with all kind of circumstantial evidence to show why the heart team is important. And I can recommend you, I hope that you will read the paper, and to see that why the heart team is so important, that you actually cannot ignore it and that you should institute it in your hospital. Then, I think what is important, therefore, we should set the patient as a center. And then the surgeon, intervention cardiologist, geriatrician, anesthesiologist, and pulmonologist should be organized around the patient. And in the past, it was much the other way around. You know, the doctor was the center, and the patient came to the doctor, and then the doctor would say, well, perhaps I need that one, and I need that one. But the whole organization in the hospitals in the modern era should be centered around the patient. So what are the advantages of the heart team? So decision-making is more accurate according to the guidelines. You have both read the guidelines, hopefully, and you can make it more accurate there. The team has more knowledge than the individual. The surgeon has some knowledge, the cardiologist has a knowledge, and you share that together, and you make a better decision. It's higher rating of patient's care. If you would need to undergo such an important surgery or treatment, and the doctor would tell you, well, I made the decision that you should be treated like this. You would value it much more if he can tell you, well, we discussed it in the team, and the whole team agreed that we recommend you to be treated like this or this. Then, the fourth one is that the physicians share the burden, and therefore you're less liable if it comes to court. For example, you can say, if you only took the decision and everybody disagreed, you can say, well, you know, we took this decision in the team and everybody agreed that this was the right decision. And then the sixth one is, it may also increase trial recruitment, that you both have open eyes for new treatments and that you can say, well, here we are really in doubt. We really don't know whether this patient should be better treated with TAVI or with surgery, and it may increase trial recruitment. And the seventh one, of course, very important. A lot of our risk scores lack some very important factors. Frailty, for example, and you can adjust it because you can see the patient together and then adjust the scores. So principles for heart team, who should be included? We heard about this. Cardiologists, non-interventional cardiologists, etc. Organize it. For coronaries, you should do it daily. Don't wait too long because then you have a huge pile of dossiers that you have to discuss. And for valves, for example, you can do it 1 time per week. You have to agree which patients do need to discuss, and you can also agree which patients, you know, can immediately go for one or the other treatment. One of the examples is, for example, if you have single coronary artery disease, you could say, well, in 99% of the cases, this will be PCI, so these don't need to be discussed. Make a local protocol. And of course, if reimbursement would be based on quality instead of the number of patients that you treat, that would be the best driving factor for the heart team. Now, the future, because guidelines need to be updated. And why and how will they be updated in the coming years? Well, patient selection is important. And what we will see, there might be a shift from TAVI towards the surgical patient population. You see, there's a population that don't benefit from TAVI, the patient C population. And then, of course, it will take some patients away that are currently are operated. And so both in the Partner 2 trial and in the TAVI trial, the line is be at the SCS score of 4. Between 4 and 10, those patients will be randomized. And that will take about 20% of the patient population. So 80% of the patients that we currently operate are patients with an SCS score below 4. So this is TAVI trial design, STS mortality risk score between 4 and 10. Heart team should evaluate it. Then you can be randomized between core valve or between surgical valve replacement. The same is actually a little bit true for the partner, almost the same design, and especially look at this intermediate risk patient population, STS score between 4 and 10. Patient can, in that TAVI, Partner 2 trial, also be randomized for transapical valve implantation. And then, of course, it will also be followed for all-cause mortality and major stroke. That's both the major endpoint in TAVI and in Partner 2. So what does it mean for surgeons? What does it mean for us? This is calibration. This is the ideal risk score, where you would predict a 5% mortality, which would correspond with a 5% observed mortality, and a 10% with a 10% observed mortality. That's ideal. You would need a glass ball, or you would need to be somewhere from heaven to accurately predict it for 100%. So if we did this in a patient population of 80,000 surgical valve patients from the United States. And if you look now at the STS score, you see that it predicts pretty good in the low-risk patient population, but it does not predict very well in the high-risk patient population. But the Euroscore 2 is worse. In the low risk, you could say, well, it is acceptable, but if you go up to the high-risk patient population, you see that the predictability is far less than the STS score. And this is the old Euroscore, the Euroscore 1, where the prediction is even worse, and especially in the high-risk patient population. Now, we all know that by now, so we say, well, take the Euroscore and divide it by 3, and then you have the actual risk for the patient. But you see, especially, they perform very bad in the high-risk patient population. What is also interesting, if you now look, what does it mean for this STS between 4 and 10? So the TAVI and partner population. So 4 corresponds with an observed mortality of 3. And 10 corresponds with an observed mortality of 8. So actually, we're already doing better than what the STS score predicts us. So we are really moving towards a more surgical patient population with TAVI implantation. So what can we conclude? There's a limited number still for indications for TAVI. It's still the older patient population who are frail and who have a high risk for surgery. That's currently what is performed. Only in trials, in TAVI or in Partner 2, you should treat intermediate risk patients. We don't know what the optimal approach is. Is it transfemoral, is it transapical, is it direct aortic, or is it subclavian? And last week I was in Medtronic, and we did some new experiments with a new echo machine for implantation of transcatheter aortic valves. And I can tell you, it may come back to surgeons, because with the tactile feedback that some of the new devices give you, and together with this echo machine, you don't need fluoroscopy anymore. And so we need to be in the driving seat as surgeons stay there. We need to learn catheter-based techniques, because if that comes back to the OR, it means that transapical direct aortic access and subclavian can safer be done in the OR than in the cath lab. Then the third one is, in the future there will be better risk stratification, hopefully, and so we can better decide which patients should get TAVI and which one could get surgery. And of course, all these new trials will lead to new guidelines, and Professor Verheyen can work for many, many more years. Thank you very much for your attention.